Hello everyone, welcome to Pulmonology Read Aloud. I'm here with the latest COPD guideline 2023 report. Recently, in last few days, we've all received this report in short PDF formats and a summary of changes. So I'm going to quickly narrate what are exactly these changes so you can just plug it in. It would be more like a podcast this time because most of these slides are already there for free download online. So let's get started. The new guideline gives a new definition for COPD. It labels COPD as a heterogeneous condition which has chronic respiratory symptoms. What it also does is that it says that abnormality of airway and or the alveoli can occur in COPD, and the previous existing terms of persistent progressive airflow obstruction have been retained. This time, a lot of emphasis has been laid on the pathogenesis and there have been updates on it. They talk about a term called genomics for COPD, where the interplay of genetics, environmental interactions, and the lifetime of the individual determine how the lung is damaged or developed. There is also a new concept called PRISM. PRISM is a concept of diseases which have preserved the ratio of FEV1 on FVC, but other impaired spirometric parameters. This is like a precursor of COPD and airflow obstruction group. They've talked about PRISM because they understand that prevention is really important and screening and catching patients early is very important. So those patients of yours who will have a preserved ratio and don't meet the COPD criteria but have other abnormalities like a reduced FVC or a reduced FEV1 alone will be coming in this category. This group of patients have poorer outcomes in terms of cardiovascular mortality in the reports thus far. So it's an important group, and it's also an important group in smokers. And they have noted that around 40 to 50% of these will develop COPD in 5 years. So they would need to be followed up. Last guidelines, the term pre-COPD was introduced. They have acknowledged that both pre-COPD and PRISM have the risk of having COPD in the future, but they need more trials for it. And they do recommend that if a patient falls in this criteria, he has symptoms, then you should be treating him. Pre-COPD term has been retained. How it differs from PRISM is because these patients have risk factors, they have symptoms, and they will have either CT abnormalities or lung function changes in the form of affected FEV1 or diffusion capacity, but still the ratio of FEV1 on FVC is more than 70% post bronchodilation. So that makes it's clear that the diagnostic criteria for COPD will remain mandatorily the demonstration of post-bronchodilator ratio less than 70%. So this has been emphasized a lot. They have also emphasized that when you're considering the risk factors, then tobacco smoking alone is not the major risk factor now. There is a lot of role of pollution, indoor, outdoor, occupational dust, vapors, fumes, and genetic factors also. What has also been done is that a whole paragraph has been given for chronic bronchitis, and they've done that because they realize that a lot of smokers, especially younger ones with more smoking, and patients with occupational exposure have a chronic bronchitis type of COPD. The definition remains the same with cough more than 3 months for 2 consecutive years, but they've emphasized that people often forget that they have to rule out other conditions that can explain the symptoms before labeling this patient as a chronic bronchitis phenotype of COPD. COPD screening has also been mentioned. They say that if your patient is asymptomatic, has no exposure, no risk factor, there is no role of doing a spirometry camp and screening for COPD in the population. But if your patients have symptoms or risks, you must perform a spirometry. So just like the asthma guidelines, this time the COPD guidelines talk a lot about spirometry. They've also talked about novel screening approaches. They've asked physicians to use a lot of questionnaires, and they've also spoken about peak flow measurements for COPD. Now, this is the first time that peak flow readings are being talked about in COPD. We used to use it in asthma for sure, but they have some evidence that these can be used, especially along with questionnaires in COPD patients. They've also proposed a new taxonomy for COPD. So this divides COPD into etiopathogenesis based types. It does not have treatment implications yet, but this could be of benefit for the research in future. They've named COPD G for genetically determined, COPD D for abnormal lung development related, C for cigarette smoking, COPD P in biomass and pollution exposure, COPD I for infections, A with asthma, and COPD of unknown cause. So this definitely opens the realm for looking out for COPD in patients with a heterogeneous group of risk factors. There is a strong mention of CT scan or radiology in stable COPD patients, and they've mentioned that not only it helps in differential, it also helps in lung volume reduction surgery planning, and it also helps in screening. So there's a special note that if your COPD patients have COPD because of smoking, you should definitely think about an annual low-dose CT scan if available. If it's non-smoker COPD, then this may not be required routinely. The classification of COPD remains same in the gold grading. So if your patient demonstrates FEV1 on FVC less than 70% post bronchodilator, then based on his FEV1, he'll be divided into gold 1, 2, 3, 4 based on FEV1 80, 50 to 30, 30 to 50 and less than 30 for very severe. Also, same emphasis must be given to MMRC scale as well as the CAT assessment, and this must be included in our evaluation of every COPD patient. This is like the previous guidelines, but they have spoken a lot about seeing the patient not only for spirometric variables but in totality. And the major change which all of us have actually seen in so many messages popping up is the change from ABCD to ABE classification. They've made the classification rather simpler now and removed the grade C, which had lesser population of COPD patients, and they've clubbed C and D to form a new E. According to the guideline statement, the MMRC and CAT will determine the symptoms. So A and B will depend on whether the symptoms are low or more. But for any patient who has increased exacerbations or increased hospitalization, they will be in group E. And this is more in recognition of the relevance of exacerbations independent of the level of symptoms in a patient. They do acknowledge that there is a need to validate this approach with research, but they have mentioned that it may make treatment determination easier for patients. So, for A and B classification, all we need is MMRC and CAT assessment, and for putting a patient in group E, we have to ask whether his exacerbations were more than one a year. This is the initial pharmacological treatment table that has been presented. A very simple table now, because group A or mild patients will receive a bronchodilator, whether SABA, LABA, LAMA. Group B receives both LABA and LAMA, and they've mentioned that it's better to give a single inhaler therapy for patients because it improves convenience and it has been proven to help in adherence in various trials. So try to give a single inhaler of LABA and LAMA for group B. For group E, LABA LAMA stays there, but in case your patient has more exacerbations or he has eosinophilia more than 300, he's the eosinophilic phenotype, then ICS must be added. So then it becomes LABA, LAMA and ICS combination for group E. So the only role for ICS really, according to the guideline in the initial management, would be for group E patients. When we initiate ICS, we already know, and the previous guideline statement had also emphasized that ICS is favored for in patients with more hospitalization, more exacerbation, or with eosinophilic phenotype of COPD. So this has again been highlighted again. For follow-up pharmacological treatment, the algorithm remains similar, but what is of note is that especially they have talked about checking adherence, inhaler technique, and comorbidities. Just like asthma, they have stressed how important it is for physicians to choose the right inhaler with the patient. Also, before you step up, you have to decide in your mind what is the predominant trait that your patient has. Is he having more exacerbations or is he having more dyspnea? If your patient is not having much more exacerbations, there is no evidence of giving ICS to him. If he's only having dyspnea as his predominant issue and is not responding to LABA or LAMA alone, you add both together. When you add both together, he still doesn't respond. You can switch the molecule, you can switch the device, you can initiate non-pharmacological measures which have been highlighted a lot in this year's statement, and you can find out the other causes of dyspnea. Only for patients who had more exacerbations and LABA LAMA is not working, we go to LABA LAMA and ICS. Now this preferentially we will do also if the eosinophilic phenotype is seen and we've done the blood eosinophilic levels. But if the blood eosinophil levels are low, again instead of instituting ICS in chronic bronchitis types, we may consider PDE4 inhibitors with LABA LAMA, or we can add macrolides. But if the count of the blood eosinophils are high, it gives us more and more emphasis on triple therapy for LABA LAMA ICS. And they've also mentioned clearly that you should also be considering de-escalation of ICS if we see pneumonia, because this exists as a potential side effect. For anti-inflammatory agents and the role of azithromycin, they've mentioned that in former smokers it works very well, but even if patient is not a former smoker, has repeated exacerbations despite therapy, you can add azithromycin and consider it for patients with recurrent exacerbations. They have discouraged the use of adding LABA ICS combination in COPD only because there is much role of LABA LAMA ICS. So if you need to add ICS, you preferentially would do it as triple therapy, and they've also talked about preferring single inhaler triple therapy for the patients. In other pharmacological treatment, a big no to cough syrups, antitussives, and also caution for using medicines used for pulmonary hypertension in patients with COPD and cor pulmonale. This time the guideline, just like asthma guidelines, have spoken a lot on inhalation device choices, inhalation device principles, inhalation therapy principles. So it's very important to have a shared decision making with the patient and see whether this patient will be able to take this device and then only give that to the patient. Also, just like previous years, smoking cessation and pulmonary rehab has been the star of the non-pharmacological measures, but they have categorized it beautifully in tables this time that for group A patients or essentially mild patients, just smoking cessation would do. However, for patients with group B and E, you start pulmonary rehab, and there's also a strong role of pulmonary rehab out of center. Vaccination is very important, and there are mainly 5 vaccinations that have been talked about in accordance with CDC. That's the flu vaccination, pneumococcal vaccination, Tdap or pertussis vaccination, COVID-19 vaccination, and vaccination for zoster and shingles has been recommended for all your COPD patients. For follow-up of these non-pharmacological measures, they've again talked about looking whether your patient has dyspnea predominantly or exacerbation predominantly. If he has dyspnea predominantly, just like asthma, self-management education, written action plans have been stressed upon, and pulmonary rehab and exercise has been talked about. If it's more in terms of repeated exacerbations, then we have to look into the aggravating factors, and we have to monitor and manage the symptoms of such patients. And also end of life or palliative care support has been given stress now. Vaccinations, as we already said, are now in recommendation with CDC, and so Tdap and shingles will be added. There is a very good table which talks about those evidences that reduce mortality with pharmacotherapy, and this is very encouraging because now finally we've started talking about reduction of mortality and not just symptom control. Amongst the pharmacotherapy, only triple therapy has been shown to have a greater effect on mortality. And in non-pharmacological therapy, smoking cessation, pulmonary rehab, oxygen therapy, positive pressure ventilation, and even lung volume reduction surgery shows a positive impact on mortality. So this is something that can be considered, and a beautiful table for this effect has been given in the guideline. They have summarized the role of not only bronchodilators and anti-inflammatory in therapy, and as I've said repeatedly, combination therapy has been given more preference. Therapy with single inhalers has been given more preference, and where ICS is added, LABA-LAMA ICS has been given more preference. In terms of anti-inflammatory, roflumilast has a strong evidence in improving lung function and reducing exacerbation in chronic bronchitis. Long-term antibiotics has also been given evidence A. Mucoregulators and antioxidants like NAC have been talked about in patients with exacerbations but with evidence B. And inhaled corticosteroids have now established a well-defined space in the guidelines for patients with group E. Pulmonary rehab, education, and integrated programs have also been stressed. So now it talks a lot about rehabilitation of COPD and combination of these two modes of therapy. The next significant change that has been brought about is in defining exacerbations. So the new definition has given the new guideline has given a new definition for exacerbation. The new definition is that an exacerbation is defined as an event which is characterized by increasing dyspnea and or cough and sputum that worsens in less than 14 days. They have also elaborated it that it may be associated with tachypnea or tachycardia and associated with increase in local and systemic inflammation. And they've also enumerated the causes for that, like infection, pollution, or insult to airway. So a lot of emphasis is being given on etiology of not only COPD but its exacerbations, so that people are looking for those things. And whenever they're talking about interventions that reduce the frequency of exacerbations, the differentiation into mild, moderate, and severe classification has also undergone a proposal for change. And this proposal is based on a Rome proposal that was published a couple of years ago, where there has been a scoring given, and based on various variables, exacerbations can be divided. Now, this is based on post hoc analysis, post treatment subgroups, but maybe in future we will be seeing better defined variables for mild, moderate, and severe classifications. Also, they have divided the interventions that you will need for exacerbations. So in terms of bronchodilators, steroids, anti-inflammatories, anti-infectives, and made it more streamlined. What they have mainly talked about is that since exacerbations are most frequently caused by a group of diseases, it's very important before labeling a patient to have had a COPD exacerbation to rule out whether it has been because of pulmonary embolism or whether it is because of heart failure, whether it is pneumothorax or effusion related, or whether it is a cardiovascular event. So such confounders have to be ruled out, and then you manage this patient as a COPD exacerbation, and this has been given a lot of stress in the chapter on exacerbation in this guideline statement. They've also summarized the management not only in severe, life-threatening, non-life-threatening, and mechanical ventilation like previous years, but these tables have changed and become more refined. The discharge criteria and recommendations for follow-up have also become defined, with tables mentioning what to do in the first 4 weeks of follow-up after an exacerbation and what to do up to 4 months of follow-up. So really a very streamlined approach so that evidence-based medicine gets incorporated more and more in our practice. In a recent change, which is a remarkable change, interventional pulmonology has now taken good place in this guideline. There are 2 tables that are specifically dedicated to surgical and bronchoscopic interventions for people with COPD. They've acknowledged that evidence for this is upcoming, and a lot of these things are on experimental basis being done, but they have used them and they have defined where and what can be used. So for patients with chronic bronchitis, they mentioned possibility of nitrogen cryospray and rheoplasty. For patients with exacerbations, targeted lung denervation can be done, and if your patient has dyspnea with bullas, then obviously bullectomy and emphysema, then airway stenting, endobronchial valves, coils, thermal vapor ablation, lung sealants, and LVRS and lung transplant have got a role in the new COPD guidelines. This beautiful table given in the guideline has divided patients into emphysema predominant patients where there are no large bullae, and they have mentioned how CT scanning can be used and collateral ventilation can be measured by Chartis and fissural integrity can be checked by HRCT. And based on presence or absence of these features, we can divide whether our patient will benefit with endoscopic lung volume reduction versus LVRS, or whether our patients should undergo vapor ablation or endobronchial valve. So that has been given a clear emphasis. And for patients who are not candidates for bullectomy or lung volume reduction surgeries or LVRS, they've talked about lung transplant as an option. Management of COPD thus has become more wholesome, and right from initial assessment and the gold ABE categorization, a lot of emphasis on non-pharmacological measures right at the time of initial treatment and management, with review and again need for checking the skills of patient for self-management, for exercises, for inhaler techniques. A wholesome approach has been given in this guideline, and it's not just about pharmacotherapy now. Much has been advanced in the non-pharmacological measures compared to the previous years. There's a chapter dedicated on COVID-19 and COPD, but in the crux they mentioned that patients should continue to receive their usual care for COPD if they develop COVID-19, and the role of NIV, HFNC, IMV, prone positioning, anticoagulation, remdesivir has also been incorporated in this statement. There is a very good checklist, a COPD follow-up checklist, which I feel a lot of us can use in our practice, and it has been given. This can help us practice evidence-based management and use these guidelines to our benefit. Thank you very much. Happy reading. So this is a brief summary of the changes in the guideline. It does not encompass the whole guideline in detail, and soon we shall have more and more updates in the future. Thank you and bye-bye.